Good afternoon. Uh, I want to call your attention to next week's session of Demystifying Medicine, which I think is really extraordinary. Uh, the speakers are two leading scientists from the National Center, the National Geodetic Survey, which is based out in Montana. Uh, it's not part of the NIH. Now, these folks do amazing work, which I heard of. So one speaker, Jonathan Sleeman, is in charge of uh, tracing the migratory patterns of everything from insects to animals, as influenced primarily by global warming and the consequences of the vectors that they carry in terms of new viruses and other agents, including fungi, that appear in connection with these patterns, which are taking place at an amazingly dramatic way, not only in this country, but around the world. And many of these are vectors of disease. There's great concern, for example, at the moment that the virus the mosquito Aedes aegypti, which carries dengue and Zika, is making really a big inroad in the southern part of the United States. And so these folks scientifically trace these migratory patterns and the biological consequences at a molecular level as well as at a broad epidemiologic level. And some of the research they do is just amazing, particularly regarding, for example, prion transfer from algae to these vectors, which then appear and produce prion disease in animals. So far, not yet in man, but who knows? At any rate, it's an extraordinarily exciting dimension, and particularly for postdocs, there's a great opportunity because they're very anxious to link exciting contemporary science, reductionist science, into the work that they do. At any rate, I hope you would come and find it interesting. Okay, so today's topic, multiple sclerosis, is in a way another example which has almost repeatedly comes up as a theme with different diseases. It's sort of like the iceberg phenomena. Disease is recognized, in this case in the 19th century, by a famous French neurologist, Charcot. These were clinicians, and they only had two tools. One was their brain and observation, and the other was an autopsy. And so what they saw, what he saw, similar to what other clinicians, as has been described here, is like the top of an iceberg of a disease. People, seriously ill, invariably sometimes, they see them in almost a near fatal kind of condition. And then as time goes on, several things happen. There's a realization that there's a life history to the disease, and many people have very milder forms, and the whole clinical perspective gets spelled out, and it becomes more complicated, not simpler. And then you get down to the level of how do you know if you have it? And there it really gets complicated because there's a desire to use contemporary science, be it imaging or chemistry, molecular, to detect, quote, early signs. And sometimes it is early signs, but sometimes it turns out that it's like a susceptibility thing. So what do you do if you have a susceptibility gene or antibody or even image? How do you deal with it? And this is a huge problem, it's not just an ethical problem, it's a basic problem in understanding disease. So multiple sclerosis is an extraordinary example of this sort of iceberg phenomena. And for those interested, we also put on the website some of the more historical aspects of the disease, which are very interesting to understand how people were thinking about it and how in some instances prejudice got in the way and other science. But the key is you needed an anatomic diagnosis. And you can't do that with the brain or the spinal cord. And so it leads to non-invasive techniques, and that's one of the topics we're going to hear about today. In thinking about this, I always go through this. All right, I can't push any more buttons. Is that it? Oh, I got the wrong one. Oh, I don't feel so badly. Okay, so these are some of the questions that pop through my head, and I'm sure through many of yours. So we'll just mention them, and I'm sure that our presenters will discuss some of it. What is the disease, and how does it all happen? And what accounts for the varied clinical course? The bottom part of the iceberg, so to speak. And why is there a gender difference? And is it true that there's really a difference in geography? And if that's the case, how does that influence what we know about? Oh, yeah. So, sorry. So, oh, come on. Well, at any rate, so So, some of the other questions that always pop up is MS an autoimmune disease? It seems to do, but what's the autoantigen? And then the things that I mentioned, like how can you make a specific diagnosis where you can't take a piece of the brain out to biopsy? And related to that is in a disease that has remissions and exacerbations, and somebody develops a candidate drug for one reason or another, how do you evaluate treatment in a disease that follows, let's call it an erratic clinical pattern? It's very complicated, and it's part of that complication that we're going to hear today from two experts. Now, I guess, and we're very grateful because they have brought one of their patients who was kind enough to tell you a bit about the disease as he experiences it. So I guess, Irina, you're going to speak first. Is that right? But I mean, okay. So I will introduce you on as a trio. So Irene Cortese is a neurologist who graduated from medical school in Rome and has been here and very early on got interested in exploring the specificity of certain bands in gels of spinal fluid in patients with multiple sclerosis. Then she trained in neurology and in laboratory science, came to the NIH as a research fellow, and eventually returned in 2005, where she's now a staff clinician, and she heads the neuroimmunology clinic, which directs clinical studies, which you're going to hear about. And this is a major challenging responsibility. And so the other speaker is Daniel Reich, who graduated from Cornell Medical School and got a PhD at Rockefeller University in neurophysiology, and later trained at Hopkins in radiology, neuroradiology, and neurology. And he's the chief of the translational neuroradiology branch of the neuroimmunology the branch here at the NIH, and is widely known for his rather extraordinary efforts and accomplishments in linking modern imaging technology to these questions of diagnosis, sort of disease progression. Perhaps we'll hear about effects of therapy and the utilization of these techniques to advance our knowledge of this extraordinarily important and challenging disease. So we will have a trio.
Good afternoon, everyone. My name is Irene Cortese, as we were introduced, and we're going to sort of tag team this a little bit. This is Alan Callender, a patient of ours for the past, how many years?
Almost 10 years.
Yeah.
Since 2008.
Okay. And he's going to be sharing a little bit about his personal experience with multiple sclerosis. And Daniel Reich.
I'll join in when it's time.
So we were thinking we would start by just asking Alan a little bit about how this disease first manifested in him and about his experience.
Sure. So can everybody hear me all right? I think so, right? I get a handheld. I don't get mic. So I was 40 years old in 2008, 39 in 07. I had just decided to move in with my partner, buy a house, and return to graduate school to get my master's degree. And it was that first semester walking from the parking lot to the classroom where my right foot started feeling like my shoe was too big or too small, or my foot was too big. And it was just an annoyance at the time. But over the course of a few weeks, my gait started to be impacted, and I started walking, started experiencing more pain and difficulty walking on that leg. To the point where my program director recognized my issues and actually raised it with me. And it was at that time that I called an on-call nurse for my insurance company and described what was going on. I'd seen my primary care physician, and he had just said, let's wait and see if it goes away in a week, or so. It didn't. And I got this feedback from my program director, and I called the nurse. And when I described what was going on, she said, "You need to see a neurologist right away." And within a few days, I had my first appointment. I saw my neurologist. In the following few weeks, we went through a number of tests to check the nervous system, and ultimately, I did a lumbar puncture and ultimately an MRI. And the conclusion at the end of those tests was that it was that I was diagnosed with probable multiple sclerosis. And at that time, we did some initial treatments to try to tamp down on the experience that I was having. So that's how I initially ended up with the diagnosis.
And so this is a pretty typical initial presentation. What I'm going to do now is just give you a few facts about MS as a beginning of a discussion as well. So MS is the most common chronic neurological disease of young adults. It is understood to be an immune-mediated chronic inflammatory disease, which seems to be triggered by some unidentified environmental factors in genetically susceptible individuals. The hallmark of MS is this inflammatory demyelinating lesion, which is referred to as a plaque in the central nervous system, associated with axonal loss as well. And the disease course is characterized by relapses and remissions of neurological symptoms, as well as progression of disability over time. Approximately 400,000 cases of MS exist in the United States alone, and about 2.3 million cases worldwide. It's not a rare disease. There is a higher prevalence in Caucasians of Northern European ancestry, and a higher incidence in women of about 3 to 1. And about 3/4 of cases present in patients between the ages of 15 and 45, which obviously imply an important socioeconomic impact of this illness. Like we were saying, the cause of MS is unknown, but various risk factors have been identified, which can be grossly distinguished into genetic, environmental, and more specifically, infectious risk factors. Genome-wide association studies have identified some 200 risk alleles. The vast majority of these are immune response genes, and the strongest susceptibility locus is by far the HLA class 2 region, with DRB1 1501 being the most significant risk variant, which accounts for about a 2 to 6-fold increase in risk of development of MS over the general population. But in general, the general population has a risk of about 0.1% of development of MS over the lifetime. First-degree relatives, this increases to 2.5 to 5%. And monozygotic twins have a concordance rate of about 30%. So clearly, the genetic contribution is only a part of the story. And the environment has an important influence. Probably the most intriguing observation from epidemiological studies in MS is the geographic distribution, which follows a north-south gradient of risk with very low risk at the equator and then increasing risk going north and south in latitude. And this geographic distribution is also seen within the United States, for example, so preserved there. Even more interesting, though, are migration studies, which have shown that if an individual migrates from one region to another region with different risk, if they move before the age of 15, they will take on the risk of their adoptive location, while if they move after the age of 15, they will preserve that risk of their region of origin. And so this implies some sort of exposure to an environmental factor, pre-puberty, which then, confers risk later. Different ideas have been suggested as explaining this, and one of them is sunlight and vitamin D levels, which in fact have independently been shown to be associated with risk of MS and certainly development of the disease as well as severity of the disease. And even vitamin D supplementation appears to be protective for MS, but the precise role of vitamin D in sunlight is definitely an active area of research. Other important environmental factors are certainly smoking, which is also associated with severity of disease. And then more specifically, in terms of risk factors are the role of infectious agents. So certainly coming from epidemiological studies that have described sort of mini epidemics of MS, and in particular the most striking is the experience in the Faroe Islands during the period post-World War II, in a region where there was no MS prior to 1943, following British occupation, which occurred in waves, there were waves of increased incidence of MS, which appears to associate with exposure to something in that related to this British occupation. And it seems to correlate actually with people who were prepubertal in the period of the occupation. And so then again, suggesting possibly some sort of an infectious or transportable exposure. Among these, EBV is definitely the infectious agent that has received the greatest attention. In fact, MS is about 2 to 3 times more common in people who have a history of infectious mononucleosis. Infectious mononucleosis is the clinical manifestation of later infection with EBV. And so suggesting maybe that the theory, the hygiene theory, where sort of antiseptic conditions that we live in now, reducing exposure to pathogens in early age, may be associated with autoimmune and allergic phenomena later in life. So regardless, this combination of maybe complex predisposition and then well-timed environmental triggers probably leads to, or is believed to lead to, activation of self-reactive T cells in the periphery, maybe through a mechanism of molecular mimicry, where a T cell is initially primed against an exogenous antigen, but then cross-reacts with a self-epitope, not identified, however. The EBV supporters also suggest that polyclonal activation by chronic EBV infection might lead to basically releasing a latent autoimmune response, which then can culminate into an immune-mediated attack against myelin within the CNS. Pathologically, this leads to the hallmarks that we talked about earlier: perivenular inflammation, predominantly represented by lymphocytic infiltrate, which then leads to demyelinating lesions around this infiltrate, and already early on in the disease, prominent axonal transection, which can then be seen later to be more widespread with axonal degeneration throughout. So what this leads to in terms of clinical course is we have patients typically will come to medical attention because, let me see if I can use this, because of development of new neurological symptoms, which will progress over a few days, reaching a peak, and then persisting for a few weeks, and then typically resolving. And already at this stage, an MRI might show the presence of a contrast-enhancing lesion, which is basically the imaging correlate of that perivenular inflammation. Already at that time, very often patients will already have evidence of there having been previous episodes of active inflammation, suggesting that the onset of the disease was probably even decades earlier, even though never meeting a clinical threshold. Subsequent disease course is characterized by recurring episodes of neurological symptoms that come and go, and this is associated also with evidence by MRI of inflammatory activity. Symptoms in MS really depend on the location of lesions and can be very variable, ranging from loss of vision in one eye, sensory deficits like Alan had presented, bladder dysfunction, weakness, loss of balance. In terms of diagnosing MS, there are some basic principles. Essentially, there is no definitive laboratory test. And what the clinician needs to do is to demonstrate dissemination of lesions in time and in space, so a chronic multifocal illness, and must also exclude, obviously, alternative diagnoses. And so the clinician will rely on medical history to identify any events that might be suggestive of MS symptoms, and of course, consider alternative diagnoses, the neurological examination to look for subclinical evidence of neurological involvement, and then paraclinical studies, including MRI and spinal fluid analysis, as well as electrophysiological studies that can aid in this. So going back, Alan, if you think in retrospect, before these first symptoms that led to the diagnosis, is there anything?
Yeah, no, I identified back in 2007 when this diagnosis was made that I had MRIs about 10 years earlier, and that was in response to a series of unexplained dizzy or vertigo attacks that I was having. And at that time, the primary care physician had done, a stress test for the heart, had cleaned the ears, and she called for an MRI also because the symptoms, they were, in retrospect, now that I understand how MS works and how flare-ups work, were very much followed that pattern. The dizziness would hit. It would hit suddenly. It would be very alarming. I would regain, normalcy, and then it would go away. And I would have a series of those that would progressively get worse over a few weeks, and then progressively get better, and then go away entirely. And this happened over a few years, and it was only in '97 where it kept happening and it kept getting worse cyclically that I had brought it to my primary care physician's attention. I feel like in retrospect that followed this pattern that you were talking about, where it can come and go and be hard to identify for that reason. I also had other symptoms that were unexplained that weren't as dramatic. Things like, for me, every time I would start to get a cold, my back would be very tingly and very sensitive to touch, and I would describe that to my primary care physician, and she couldn't explain what that was. And essentially, I wrote it off as aches and pains that you would get with a regular cold because I couldn't call it anything else at that time. But that seemed like a sense of, and then I'd feel that, and then I would get the cold, and it would almost always precede getting the cold. So it's like my immune system was, predicting that I was going to get a cold or something. Again, in retrospect, it feels like those things were, for me, well, now I think early, and then the MRI that I look at today, and I think I see what I know now as lesions. So,
And I think,
if you go back even as far as high school, is there anything that you can point to, or it really started in your 20s?
well, I mean, I feel like through high school, I did, seem to have a lot of colds. So, I mean, I don't know if that counts, but, I had some back issues, which I don't know I don't know if those were
Did you ever have
indications.
mononucleosis?
Yes. Yes. I think,
How old were you at the time?
I mean, I think it must have been at least once in high school and tested positive when, again, done as a young adult in my 20s. I'm certain that because I was getting things like, colds or strep like once every 3 months for a while. So
The epidemiology of Epstein-Barr virus is kind of interesting in the sense that it's a ubiquitous virus that, as you said, it affects, 90% of people have antibodies to Epstein-Barr virus. But in people who have multiple sclerosis, the number who don't have a history of Epstein-Barr virus infection serologically is vanishingly small, and the number who've had an infection that manifests as mononucleosis is far higher than in the general population. Although far and away, most people who have EBV and who have mononucleosis never develop clinical multiple sclerosis. So it's an interesting thing.
If you have a disease that's common enough, it'll correlate with anything.
Right. Yeah. I mean, there's some reasonable mechanistic data supporting that there could be a link, but of course, if you look at a list of the viruses that have been implicated as the cause of multiple sclerosis going back 150 years or so, I mean, the list takes up several columns of fine print in a textbook, and measles virus and HIV at one point. So, but that's the virus of the day. I mean, to the point where the link has really survived probably for a decade or more now. I mean, to the point where vaccine studies are beginning to be planned, which would be an enormous undertaking.
So I'll just briefly mention the oligoclonal bands. Alan also underwent lumbar puncture. The typical finding in MS is the presence of these oligoclonal antibodies in the spinal fluid that are not present in the serum, and these aren't present in a normal individual. And these are taken to indicate intrathecal inflammation. The specificity of these bands is unknown. It seems to be polyclonal, and the patterns are very individual and not shared across patients, which again sort of supports this polyclonal activation idea. Bands are present in about 98% of people with MS. And so it's considered a very specific or a very sensitive finding, but they're certainly not exclusive to MS. Any infection or immune process affecting the CNS might be associated with these bands. So
and it's worth pointing out that actually in the context of what we were talking about, that if you look, you can find in somewhere around 30 to 40% of patients bands specific to Epstein-Barr virus antigens.
But also to almost every
to other herpes viruses. But it's anyway, we've published on that a little bit.
Mm-hmm.
Okay.
Maybe you want to ask the audience would like to direct any questions.
Yeah, we can pause now for some questions. I mean, I think we'll get back to Alan a little bit later, but no problem stopping now.
Any eye signs?
I have not. I have not. No.
One question for Alan and one question for researchers. For Alan, you mentioned, I was curious because you mentioned that when you started graduate school, one of your instructors or program person was early on in identifying something of concern, more so than your GP, and that's what got you to go to the neurologist. And so I was assuming that you must have been a student in a neuroscience program, and then I saw you've got MFA after your name.
Yes, I was in art school. I was in art school, and it was my art the program director in art school. He just said, "You're not walking right. You look like you're having difficulty walking. You should talk to somebody." And so that's when I called the nurse, and it's the nurse, the insurance nurse on call. I was walking from the parking lot to class, and I called at that point, and she's the one who said, after I described the situation, I'd seen my doctor, I'd been having this for a while, it seems to be getting worse. She said, "You need to see a specialist." So I was really, I give her a lot of credit for making the call.
It's the way insurance is supposed to work.
Yeah, it really truly surprises me, frankly.
I felt in your telling of the story that there was kind of a, like, why didn't my GP pick up on this when I told him I had problems?
He is not my GP right now. I changed my GP. I went back to the one I had who originally in '97 actually did everything right. In retrospect, that I switched.
But just to point out that the diagnosis of MS can actually be quite tough, and ordering the right, we'll talk about MRI in a minute, but ordering the right test, it can sometimes take time to get to that point. And we are making diagnoses rarely, but occasionally in people in their 60s or older. So.
I was just going to add, I will say, just in his defense, the next test was one that was going to be very painful, and he was trying to spare me from having to take that test. In retrospect, I would have preferred the painful test, the EMG test. Yeah.
Right. Which would not have really helped in this case.
Okay.
Any other?
Oh, my other question was going to be that knowing the connection, the very strong correlation between having mononucleosis as a young person and later and people having MS. Is anything being done about that? I mean, like as far as
Excuse me, can you discuss this at the end, because
oh,
we have an opportunity.
I'm sorry, I thought they said to take
Sorry.
questions now.
Any other questions? Anyone else? Okay.
All right.
Please go ahead.
We'll go on, and there'll be other opportunities, I'm sure. So I'm just going to talk a little bit about MRI and how we make the diagnosis of MS. So here's an MRI scanner, and just sort of, because I'm sure there are some people in the room who know how these things work, but there are others who may not. I'll just, on a very basic level, talk about how we make images in the MRI scanner. And essentially what it is a magnet. The magnet is when you put somebody inside the scanner, due to the magnetic field, the protons, which make up most of our body, which are always spinning around at a very rapid rate, will align in the direction of the magnetic field inside this magnet. And that happens very, very quickly. And they're all essentially aligned in the same direction. And what we can do is to deliver a pulse of radio frequency energy into the magnet, into the person who's inside the magnet, and that will perturb the magnetization of the spin of the protons that are inside the person. And then we can just watch, using essentially an antenna, we can watch these protons relax back into alignment inside the magnetic field. And there's a lot of physics behind that, but the reason that that's useful medically is because depending on which tissue the protons are in, the rate of relaxation will differ. And there are a number of time constants or rate constants that are really characteristic and that we can measure in the MRI scanner. And we can use those to make images of really any part of the body. But we're interested here in the central nervous system and in particular in the brain and spinal cord. And so when we make pictures, when we make images that are weighted to telling us about these different rate constants, the relaxation rate constants, we get these two types of images, which are called T1 images and T2 images. And you can see that structures in the brain appear different depending on what structure they are. So for example, so for example, in the T1 weighted image, you can see that the fluid in the brain, this is cerebrospinal fluid inside the ventricular system of the brain, is dark over here. That means it actually has a very long time constant of relaxation. The gray matter, the cortex, where the cell bodies of the neurons are, is dark. And the white matter, where the myelinated nerve fibers are, is bright. And that's because the myelin, which is mostly a fatty substance, has a very rapid relaxation, and that shows up as bright on this image. And then on the T2 image, the cerebrospinal fluid shows up as bright, excuse me, so we can see the ventricles very nicely. We can see this cerebrospinal fluid surrounding the brain in the subarachnoid space very nicely as well. And that outlines structures such as, for example, the chorial plexus, which is inside the ventricles. And we actually don't get very good contrast within the brain between the gray matter and the white matter on this type of imaging. The T2 times of gray and white matter are quite similar. But as a radiologist, I use these two types of images and a few others every day to try to figure out what is wrong, where there are abnormalities in the brain, and then I have to kind of use my knowledge of how they'll show up on these two types of images and a few others in order to figure out what the diagnosis is. With respect to MS, there's, in addition to these images that we can take just of immediately after we put somebody inside the scanner, we can also get functional information using contrast agents. And in MRI, most of these contrast agents are based on gadolinium, which is a heavy metal. It's a rare earth element that has the effect of shortening the T1 time of protons that are in its vicinity. And so chelates are made, which are safe when used appropriately. And normally the brain, the blood vessels in the brain are not leaky, so that gadolinium contrast agents injected intravenously will travel up to the brain and they won't get out into the brain parenchyma itself. There are a few parts of the brain, such as, for example, the pituitary gland, where we do see that the gadolinium leaks out normally in people without any disease, but in general, the brain does not really change very much after we inject gadolinium. But that's not the case in multiple sclerosis, where, as Irena mentioned, there is often inflammation around blood vessels, and acutely that inflammation can be associated with leakiness of the blood vessels and abnormalities of the blood-brain barrier, which is really what is blocking the gadolinium from getting out into the brain. So as an example, here are two images. They're both T1 weighted images, but one is taken before the gadolinium is injected, and then one is taken about 5 or 10 minutes after the gadolinium is injected. And you can see on the image here, on this side, it's very similar to what I showed you. The white matter is bright. There are a few dark spots here, which actually represent are areas where there are lesions due to multiple sclerosis, which we'll get back to in a bit. But on the post-gadolinium image, you can see, of course, that the structures that enhance normally, including the choroid plexus, including blood vessels in the subarachnoid space, including the dura mater, which is the thick membrane that covers the brain. So we can see that very nicely over here. But of course, your eye has already picked up this spot here, which represents an area where the gadolinium has actually gotten out into the brain. And if you look closely on this image over here, you can see there's a dark spot over there. And so this actually tells us a lot. It tells us that there's active inflammation going on in MS. It actually tells us a little bit about the age of that area of active inflammation, and I'll get back to that in a bit as well. And again, feel free to stop me if there's anything I can expand on. No, there are various chelates that are used, linear chelates and macrocyclic chelates, and they hold on to the gadolinium more or less tightly. There are some that are, the chelate binds to albumin, so it remains intravascular even. So in this case, that chelate would not show us anything on this image, but typically the ones we use dissociate to some small degree and then we'll get out. But the important point to, from an MRI point of view is that we're not actually imaging the gadolinium, we're imaging the protons that are near the gadolinium, whose relaxation properties are being changed by the gadolinium. So it's extremely valuable clinically. So what do we see when we image somebody who has multiple sclerosis? So here again are two images. This is a type of image I actually haven't shown you before. This is called a FLAIR image. It's actually a T2 weighted image where we've done something to suppress the signal inside the water, inside the cerebrospinal fluid, so that's dark, but leave these areas that are rather watery, which are actually the lesions of MS, bright. And so you can see in this person, there are these discrete foci right up against the ventricular system, or sometimes deep in the white matter, sometimes right up against the cortical surface down here on the bottom, that are, again, representing areas where there has been some tissue damage done. This is a similar picture, maybe it's the same person. This lesion here is the same as that one over here, but of course we're now slicing the brain sagittally or parasagittally. And you can see that these lesions really can occur anywhere within the brain. And in this instance, there are many of them, not all of them, but many of them are actually leaking gadolinium, as you can see here. So on the T1 weighted scan after contrast administration, you can see that many of these lesions are lighting up. And they actually here are lighting up in a very characteristic way that make somebody with experience look at that and say, yes, for sure, this is multiple sclerosis and an active case. So MS was first studied with MRI very soon after MRI scanners started being made. MRI images, the earliest ones are sort of mid-70s, late 70s. The first paper describing an image of somebody with MS came out in 1981. The first use of gadolinium in MS was in the mid-80s, in 86 or 87 or so. In the late 80s and early 90s, actually, the first time MS was studied here at NIH with MRI was in 1989, and we have some of those images still in our digital archive from people who are still coming back to this day. So a lot of experience was gathered in those early days, and eventually, based on that, people started to get together and say, well, what are the typical characteristics that allow us to distinguish MS from other diseases? So one of the first papers, this is one of the first papers describing that. What are the really characteristic features of the lesions of multiple sclerosis that allow us to say this is MS? And so I'll show you some of those. Lesions that are in the periventricular region, so abutting the lateral ventricles, as you can see here in the axial plane, and here in the sagittal plane, they actually kind of stick up like thumbs out of the ventricle, and I'll get back to that a little bit later. So that's one of the very characteristic features of the disease. Juxtacortical lesions, which means the lesions that are right up in the white matter, but right up against the cortical surface. So you can see some nice examples of that in this patient over here, how this lesion here is focused right up against the cortex. Here's another one. We know now actually that most of those lesions actually involve not just the white matter where the myelin, most of the myelin is, but also the deeper layers of the cerebral cortex as well. And here you can see that that particular juxtacortical lesion enhances following gadolinium, although the one below it does not. Also, the presence of lesions in the brainstem and cerebellum, as shown here on this T2 weighted scan. So here in the middle cerebellar peduncle, right up against the fourth ventricle, here in the pons. Very characteristic of the disease and actually very, very helpful in distinguishing MS from other. There are many things that can cause white spots in the brain on an MRI, notably small vessel disease, which often comes from hypertension or smoking, hyperlipidemia, but doesn't cause lesions in this region like I'm showing you here. And then very importantly, not just for the diagnosis, but also probably for the disability that accrues in this disease are lesions that occur in the spinal cord. And so here you can see a sagittal T2 weighted image of the spinal cord. Here's the spinal cord, here's the vertebral column. It should be black because it's a T2 weighted image. White matter is black on those images, but you can see these foci, these dots that represent bright areas that are, again, the very same thing that happens in the brain is happening here in the spinal cord. And on the axial image, you can see that the cord also has bright signal within it. So that's representing areas where there's a lot of water and causing prolongation of the T2 relaxation rate. And I mentioned already the gadolinium enhancing lesions that we see, and this very, very characteristic finding that actually we've been quite interested in the lab over the last 6 years or so is understanding what is this ring, what we call a ring enhancing pattern here, where in this case you can see an open ring with the opening of that ring right up against the cerebral cortex. And why does that occur? Here the open ring is up against the ventricles. Based on those early studies and kind of the accumulation of experience about how MS appears on MRI, MRI actually became the central test for making the diagnosis of MS. And you can see Henry McFarlane's name on this list of authors. Henry was the head of the neuroimmunology branch here for several decades and contributed greatly to the understanding of the disease through MRI. And so MRI became a critical aspect of the diagnosis of MS here in 2001, and this set of criteria has undergone multiple revisions in the last 15 years or so. Most recently, in this paper just published this year, where these criteria have been enumerated, that Irena mentioned dissemination in space and time, and actually we can demonstrate both of those by MRI in MS by dissemination in space by showing 3 or more periventricular lesions, 1 or more infratentorial, so brainstem cerebellum lesions, 1 or more spinal cord lesion, 1 or more optic nerve lesion. You asked about visual symptoms, 1 or more cortical or juxtacortical lesion, and you need to have at least 2 of those, and that gives you some extra specificity for making the diagnosis. And again, dissemination in time, which is showing that lesions happen not all at the same time, but at different times, can also be demonstrated in MRI, because we know that the gadolinium leaks into lesions in their first 4 to 6 weeks or so after they appear. And so if we see lesions, as I showed you, that are present but don't have any gadolinium leakage, that would suggest they occurred earlier. So we know that the dissemination in time can occur. What are some other features that are important for us to note when we look at MRI scans of people with MS? One is, I mentioned before, that the lesions are bright on T2 weighted scans. They can be dark on T1 weighted scans, and that's been correlated with more destructive pathology within the lesions, transections of axons, and loss of brain tissue. And so you can see some of that here. The visual system was mentioned. So optic neuritis is a common presenting syndrome of multiple sclerosis. About a third or so of patients, their first symptom of MS is a transient loss of vision in one eye. And that's called optic neuritis. And you can see here that these are the optic nerves. Here's the left optic nerve. It's dark, it's black. Why is it black? It's because the optic nerve is a myelinated structure actually of the brain itself. So it looks just like the white matter of the brain. It has some cerebrospinal fluid around it that's bright. And you can see here the optic nerve is not well delineated. It's substantially brighter than its counterpart on the left. And that's because there's inflammation going on there. And actually, when we give gadolinium, the optic nerve does not normally enhance. As you can see in the left eye, the extraocular muscles enhance very nicely. That's a normal finding. On the right side, the extraocular muscles are enhancing, but the optic nerve is very, very bright. So just like in the brain, when we have active and acute inflammation, in the optic nerve, it's exactly the same thing. And then again, in the spinal cord, I mentioned that already, and this is another case showing you on 2 different types of images, T2 weighted image, and here a proton density weighted image, bright signal in the spinal cord. I mentioned cortical lesions. This is an area that has been of intense interest in the last 10 years or so, because it turns out that if you do immunohistochemical stains for myelin proteins, such as proteolipid protein or myelin basic protein, you can see that there is a tremendous loss of, again, a focal loss of those proteins within the cortex that does not show up on nearly so well on typical myelin stains, such as the Luxel fast blue stain, which is sensitive to phospholipids. But if you look for the proteins, you see that they're abnormal in the cortex. And we've had a really hard time finding those on MRI. So, you know, the early MRI scans, even though they were done with magnet strengths, you know, more than almost 2 orders of magnitude weaker than what we have today. The lesions were very, very obvious, but in the cortex, we're still having trouble seeing them despite all the increases of technology. So there are various ways that one can look at this. One of the world experts on this is actually a postdoc in the lab currently. And so here's an example of one such lesion in the cortex of somebody with multiple sclerosis. Something else that has been recognized is diffuse tissue abnormalities. So from the pathology point of view, and the way we've been describing it, MS is really a disease that is multifocal. It causes these focal lesions. That's what we see on the MRI. And here's an example of a lesion. But it turns out that there are areas of the white matter that really are subtly abnormal when you look at them. And that's been described somewhat, unfortunately, as dirty white matter. And then areas of normal white matter. And what is the basis of these sort of subtle abnormal signals? Does that have to do with sort of downstream effects of the focal lesions, or is there actually local pathology? It's not quite clear. I mentioned Dawson's fingers, or I mentioned these finger-like appearance of the lesions coming out of the ventricles. They've actually been called Dawson's fingers, because just let me finish the slide and then I'll answer it. Dawson was a neuropathologist who worked in Edinburgh about 100 years ago and described this appearance of the lesions that come out of the ventricles, and he defined the reason for that. And the reason for that simply has to do with the normal venous anatomy in the brain, because the penetrating vessels, the penetrating veins, radiate out from the ventricles, or actually flow into the ventricles or flow out into the cortex. And it turns out that the inflammation in MS forms around those lesions, as I'll show you in a second. Sorry. Yeah. Right. So that's a great question. It turns out that most of what people have described as far as the dirty or diffusely abnormal white matter is probably showing up sort of later in the disease. And one thing we know, and Irena, I think we'll get back to this, is that the lesions actually in general, stop forming after 10 or 15 years of the disease, which is a really interesting question. So I think that most of this has to do with kind of long-term downstream effects of prior inflammation. But it's still a great question, because there have been some studies that have done serial scanning of people with the disease monthly. In fact, here in the 90s, there was a cohort of several dozen people who came in every month for years. And they did that. If you go back and you look at areas that later formed lesions in those locations, you're able to pick up specific abnormalities. We've tried to revisit that recently using high field, high resolution imaging, and have shown, at least in some cases, that process is not a sort of diffuse tissue preconditioning, but rather something focal going on around these blood vessels. And the reason we can do that is because we now have ways of making MRI very sensitive to the presence of blood vessels, and that has to do with generally an endogenous contrast mechanism. So in veins, the hemoglobin is in a deoxidized form, and deoxyhemoglobin has the property of being able to cause very subtle shifts in the magnetic field locally. And it's that property that is actually the basis of functional MRI. We're not doing functional MRI here, but that's why functional MRI works. In this case, what we're doing is we're taking very high resolution pictures of the brain, which we can do very rapidly. These are images that have a resolution of about 0.5 millimeter on the edge of each pixel. And what you can see when you do that is that the lesions, which are bright spots, as I showed you before, actually have these dots in the center of them. So here, for example, are dots in the center of all of these lesions. And if you look in a different plane, that dot may actually be a line. So what does this represent? This actually represents the blood vessel around which that lesion has formed. And if you look at it this way, you can actually see how sort of beautifully symmetric the lesions are around the blood vessels, really strongly suggesting that the origin of the lesion is actually that blood vessel in the center that can be inflamed. And we're trying to now in our lab work on the pathology of this, and why is this blood vessel so prominent? This may turn out to be diagnostically very, very helpful down the road. So that's one feature that has been really interesting to us. Another feature that we've picked up on using high field scanners. So here we have a 7 Tesla MRI system. There's probably about 5 dozen or so of those in the world. and they're able to take pictures at higher resolution and also to give added contrast where you have these substances like the oxyhemoglobin that can shift the magnetic field a little bit. And it turns out that in some fraction of MS lesions, there is an accumulation of dark substance that can occur around these lesions. So I'm showing you here on the bottom with these arrows a dark line that you can see at the edge of this lesion, and we believe, and we have evidence for this now, and several groups also have corroborating evidence that this represents an accumulation of iron at the edge of these lesions, right at the edge of these lesions within macrophage. And that's really interesting. I'll show you some pathology in just a minute. So we're left now 100 years after Dawson showed pictures, drawings like this, or images like this. This is from Dawson's original monograph. As Wynn mentioned at the time, the tools were the brain and the autopsy, or in this case, the autopsy of the brain. And the images that you see in Dawson's work are really now able to be recapitulated non-invasively in the MRI. I mentioned the pathology. We're still very, very interested in the pathology, and we've had patients who have very generously donated or made arrangements to donate their brain. And so this was one example of a patient who we first started scanning in 2006. Actually, I studied this patient when I was in my fellowship at Hopkins. And then he came here later and passed away from causes unrelated to MS in 2013. But we did have the opportunity in this person to examine what was the basis of some of the things that we saw on the MRI scan. So here you can see 2 scans showing initially in 2006, 3 lesions, dark on the T1 weighted scan right around the ventricle. By 2013, at least one of these lesions has enlarged quite substantially. On the scan that we did of the brain, we took the brain, we fixed the whole brain, and then put it in the 7 Tesla scanner for roughly 30 hours or so. You can see this line around the lesion. I showed you that before. That's that dark band. And then the corresponding tissue showing you absence of myelin on the Luxol Fast Blue stain, absence of myelin proteins on the proteolipid protein stain, and then disruption of the axons here on the Bielszewski stain. At the edge of that lesion, there is a dense collection of CD68 positive cells, which represent macrophage or microglia that are just sitting at the edge of this lesion that we know was at least 7 years old, if not maybe decades old. And there are PAS positive granules within the cell. There's also iron within those macrophage right at the edge, which accounts for this contrast that we see. And we believe that this may represent areas, well, it certainly is an area of persistent inflammation at the edge of the lesion. And what role these macrophage have in the enlargement of that particular lesion from 06 to 2013 is something we're very interested in. So I'd like to just come back to Alan and show you some of his scans. So now you know all about what distinguishes the MRI of somebody who has multiple sclerosis. And all of those features that I described were evident in that first scan that we did of Alan before I got here, but that was done of Alan here at the NIH. So you can see Dawson's fingers in the periventricular region on the sagittal scan, on the parasagittal scan, and also on the axial scan. You can see an infratentorial lesion that's dark on the T1 weighted image here in the middle cerebellar peduncle. And at that time, here's a lesion that's enhancing with gadolinium right up against the cortex. So it has that characteristic open ring pattern where the gadolinium actually doesn't leak directly into the cortex. So you can, in this instance, immediately make the diagnosis of multiple sclerosis from this image alone because it demonstrates meeting multiple of the criteria for dissemination in space and also dissemination in time. And Alan mentioned that he'd had a prior MRI scan back in the 90s, which is in that manila envelope on that chair over there, but we have one image here which shows that actually on that scan, and sadly this was missed by the interpreting doctors at the time, but clearly there is a focal lesion here right up against the cortex, and we can still see that specific lesion today when we do scans of Allen. There was also, I think when we looked at it, we found a couple of gadolinium enhancing lesions even on that initial scan in 97. Allen's spinal cord is shown here. You can see several lesions in the cervical region. Here's one over here, another here, and here's one in the thoracic region. This is the appearance of the lesion in axial section in the lateral column, which is where the corticospinal motor fibers that are passing down to the arms and legs will traverse. You asked about visual symptoms in Allen. Allen hasn't had visual symptoms, but his MRI shows that in fact there is an abnormality on one of the optic nerves. This one is clearly brighter than its counterpart on the other side, suggesting that there was subclinical inflammation even in the optic nerve, which I think is really remarkable because we've told you that there are many lesions that are asymptomatic that can occur in this disease, but for a lesion in a structure as neurologically eloquent as the optic nerve to be entirely asymptomatic, not cause any problems for Allen is sort of remarkable. And then we can do that kind of vein imaging that I showed you before in Allen as well. And here's an example of how one of the lesions, or several of the lesions that Allen has are again centered around that dot, around that blood vessel. And this particular lesion has that dark rim around it that I described as well. All right, I've talked enough for now. Any questions before we get back to move on to treatment? Yeah.
When there is disappearance of the lesion upon treatment,
Yeah.
what's the relation between permeability
Yeah.
and remyelination?
That's a large part of the effort that's going on in the lab right now. It's not a simple question to answer. When we give medications, all of the medications that are currently approved for MS, they don't make the lesions that exist go away. They simply reduce the chance that a new lesion will form. Yeah, we still see them. They're still there. We see that there has been demyelination, there has been scarring, and there's been axonal loss. We can still see that, and that will persist forever in that person. So the goal of therapy, of the therapies we have, of the treatments we have, is largely to stop new lesions from forming at this point. And I think we'll get a little bit into how we can monitor that with MR, right? Okay, but now it's you.
No. Are there any other questions one wants to ask at this point? Okay, wait, may I ask one?
Yeah.
So in the old experiments, I think of Thomas Rivers, as I recall, who injected myelin and made antibodies and created allergic myelin demyelinating disease.
Animal
Is that a useful model both for the study of the disease at the cellular level, because there you can get tissue, and from the imaging standpoint of?
I think that EAE, which is what you're referring to, has been a very useful model for understanding some of the basic mechanisms underlying MS, but it's definitely not the same as MS. So in the EAE models, you know the antigen that you're administering, and the background is usually very homogeneous, and there's a very predictable course. So there are many differences with actual MS, but it's been very useful in teasing out basic mechanisms. Interestingly enough, a lot of the disease-modifying therapies that work very well in EAE, we can cure EAE very, very well, don't work in MS, and vice versa. So there are clearly big differences between the models. I think from an imaging perspective, it's been very, very useful, and you might.
Yeah, we
more to say.
so the mouse model of MS EAE is induced, as you said, by injecting myelin antigen, usually with an adjuvant. And in the mouse, this causes an ascending paralysis. So it starts in the tail and hind limbs and moves up to the forelimbs, and it's generally a confluent spinal cord lesion that occurs on pathology, generally in the lower sort of thoracolumbar cord. MS, as I showed you, is a multifocal disease that can involve any part of the central nervous system, brain, spinal cord, optic nerves, and tends to cause focal lesions rather than these confluent lesions that are seen in EAE. So there is quite a difference pathologically. We have been using, about 6 years ago or so, we revived a model that had been used here 15 years ago, which is a primate model of MS in the marmoset, which is a small New World monkey that has a much pathologically much greater similarity to human MS. Part of the so when you induce EAE in the marmoset using, again, the same way by myelin antigens and an adjuvant, they will get multifocal lesions in the brain, in the spinal cord, that under the microscope are indistinguishable from MS lesions. And so that has been immensely useful to us in terms of understanding the radiological pathological correlate of the disease. And some of those phenomena that I showed you, like that dark rim around the lesion, we're trying to chase that down in the model now. But certainly we can see the veins at the center of the lesion very nicely in the marmoset.
Would you like to tell us a little bit about what happened after your diagnosis?
Sure. So in 2008, right after the diagnosis, to kind of halt the more extreme symptoms, which were the foot and also a very uncomfortable tingling and strange sensation that rose up the leg, up the back to the neck. It was very distracting. To address that, we did. I was given steroid treatments, like 3, 5, or 10-day IV, whatever you call that, treatments that, presumably then stopped, halted, maybe reversed the presence of the symptoms, and it did seem to work. Then I think in a year or so, I was finally, from that, so 2009 around, I was finally put on a interferon drug that was on the market, approved, one of the 3. I was still having these flare-ups periodically, maybe once every 3 months, once every 6 months. They were getting worse when they happened. So after a few years, it was decided that the interferons were unlikely to be sufficient for controlling the progression of MS in me. And by this time, I had an ongoing relationship with NIH. I'd been participating in the life, what do you call that? The
Natural history study?
natural history study. I mean, getting my brain scanned periodically, and there was a drug that was available for consideration when interferons weren't doing what they was supposed to do, and the disease progression, or the disease was progressing, and that was daclizumab. And that's what I'm on now. And though it took a little while to stop the flare-ups, it has now been a few years, 3 years more, where I've not had any flare-ups, any no contrast enhancing lesions on MRI. I get MRIs still, every 3 months. And so for 3 or so years now, both symptoms and MRI indications suggest that things are working well. So that's where I am. I take other drugs for symptom management, but those are the main ones for the disease. management.
So Alan has participated in a clinical trial here at NIH using the experimental drug that he mentioned, daclizumab, which is an anti-CD25 monoclonal antibody, which was actually developed here at NIH by Tom Waldman, and then applied in the MS scenario with the idea that it might suppress T effector cells. In reality, subsequent studies have shown that probably this drug, which is very effective at suppressing inflammatory activity in MS and inhibiting relapses from developing, and also new lesions by MRI, it appears that the mechanism is probably more complex and wasn't predicted by the known target of this monoclonal antibody. Just to very quickly say how it's thought to act is by blocking consumption of IL-2 by effector T cells. This leads to there being an excess of IL-2 available, which is then used by NK cells, which do have IL-2 receptors and appear to expand dramatically in response to the available IL-2, and then have a regulatory effect basically in suppressing the active immune response. And so in this sort of indirect way, which wasn't predicted, actually end up having a very favorable outcome in controlling MS. And this drug it's a success story at NIH because right now it's under review at FDA and expected to be approved probably this summer for use. So just to talk a little bit about treatments in MS, the options have really dramatically changed over the last decades with the very first FDA-approved disease-modifying drug, which was beta-seron in '97. And then since then, we've had an explosion of medications that are available for treating relapsing remitting MS. Again, these are preventive medications that suppress inflammatory activity, suppress relapses, and active disease by MRI. There are now 13 different formulations that are FDA approved. Alan mentioned, though, that often the list of medications that a patient with MS will be on will be much longer than just a disease-modifying treatment, and will include symptomatic therapies for example, dealing with sensory symptoms or spasticity or to improve bladder function. And in addition, in the setting of an acute relapse, we will very often use IV steroids in order to dampen that active immune response immediately. So all of these medications that are approved do target immune mechanisms in different ways. So for example, they might trap immune cells in lymph nodes like fingolimod does, or like daclizumab does. It blocks CD25 receptor, allowing NK cell expansion, or might block penetration of immune cells into the central nervous system. And so they all have a very similar sort of mechanism in trying to dampen the immune response. All of these drugs have side effects, as any drug does. And we've been talking about daclizumab, and the most common side effect of daclizumab treatment is rash. Here you see photographs of examples of the types of rash that can develop in patients with daclizumab, in treatment with daclizumab. For the most part, these rashes aren't treatment limiting. About 10% of patients who are enrolled in our study ended up dropping out because of severe rash. And Alan, one of these photos is yours. I'm not going to say which. Alan did experience rash as well during the course of his treatment. I don't think that has been as much of an issue recently.
No, it's largely, it feels like it's largely decreased over time, and it is also something I topically treat. So as soon as it starts to show up.
So most of the patients who were enrolled in our study experienced similar types of rash that came up probably in the first year of treatment, and then getting over that hump was enough to be able to continue even for years. We have patients who have been on teclistamab treatment now going on, let me think,
12 years.
10 years
Yeah.
at least. And so that seems to be the case. But in some cases, you can see here, there can be some pretty dramatic rashes. So this is a plot that is trying to depict the relationship between efficacy, which essentially is related to the degree of immunosuppression that is afforded by an agent, either because it is a broadly immunosuppressive agent or a very targeted but robust immunosuppressive effect. And this is typically, drugs that are more effective are associated with a greater risk for even life-threatening complications. So the rash worries us less, but opportunistic infections, sometimes fatal, are really the ones that we fear the most and that are a problem with some of the drugs that are used for treating MS. So we have 13 different formulations approved, but the efficacy is variable, and there is always that concern in the background of the side effects. So our goals in caring for people with MS are to obviously reduce accumulation of disability over the long term, to improve quality of life, so reduce relapses, minimize inconvenience. Many of these drugs are injectable agents, some of them daily injections, and then obviously to contain costs. There are different algorithms that are used for treating MS, but for the most part, our approach is to treat early disease or mild disease with first-line agents that have minimal side effects, and only if we see treatment failure do we then escalate to the more the stronger medications that have a greater risk profile. And at any time point, either here or elsewhere, clinical trials are an option, as Alan took advantage of as he was being followed here. And you were going to talk a little bit about MRI and treatment. Mm-hmm.
If the lesions don't go away, why do symptoms?
So that's a great question. So symptoms in the acute setting of a relapse, symptoms are probably due a little bit to functional impairment due to the active inflammation. As that active inflammation subside, the symptoms will largely resolve, especially early in disease. And so it seems that there is more of a conduction block that is related to active inflammation that is probably contributing to the sort of dramatic onset of symptoms, which then remain at their peak for probably a few weeks, and then come down more slowly, often back to baseline. With steroids, we can accelerate that improvement, and most likely because we're resolving that acute inflammation. Over time, as we saw earlier, though, what can happen is that there isn't a complete return to baseline, and there can be some degree of residual symptom that remains after relapse, and this can steadily increase over time. And I don't know if you would like to comment on that at all.
Yeah, sure. I mean, for me, the whole diagnosing event was in my right foot, and it was tingling sensations like somebody's squeezing it really tight, or my shoe was too tight, or whatever. During the flare-ups, those sensory distortions would get really bad, go up my leg, go up my back, all the way up to my neck, and then go back down. And sometimes early on, they felt like they would go away entirely. But over time, they went away less. So once I was on teclistamab, I didn't have any of these I haven't had any of these, crazy, intense, acute, weird sensations going up the back to the neck. But the sensations that my shoe is too tight or somebody's squeezing my foot too tight has slowly gotten worse, and is actually in my left foot as well now. And I can try to work with that through physical therapy and strength training and whatever the other, things I can do, some gabapentin, drug therapy. But I can tell it's still there. I can still tell. And I think it's slowly over the years getting a little bit worse.
So initially, also the demyelination certainly predominates over axonal injury. And what can happen very commonly is that patients may return to their baseline, but then under stress or when exposed to heat or to infection, then old symptoms can reemerge. And this probably has to do with less effective conduction of signal in regions that have been demyelinated, and where you can have dispersion of signal conduction because of the loss of that insulation, which is normally present. Over time, probably this chronic demyelination is going to lead to some sort of suffering of those axons so that eventually they may degenerate. And this is thought to be happening from the early stages of MS, but certainly becoming more prominent over time. And that might be, in part, the explanation for the clinical course with this slow accumulation over time of symptoms and reemergence in certain periods of old symptoms.
You just reminded me. I will say that the heat, like
Mhm.
with Washington summer heat, humidity, is very difficult. And fever, like when I get a fever, the symptoms like crazy come in. When the fever breaks, it breaks. It doesn't last like the flare up did, or it doesn't last like but yeah. So.
Yeah, some patients will wear a cooling vest in order to help tolerate effective heat. So the heat effect, which is actually called Untoff's phenomenon, is quite prominent in patients.
How are we doing on time? Okay, we'll talk for a bit more and then move on. So we talked about the drugs. I mentioned that the medicines that we have are effective by reducing the incidence of these new lesions, these gadolinium-enhancing lesions. So here, there you go. 2 gadolinium-enhancing lesions, give the drugs, and they're not there anymore. And we can quantify this on MRI by using fancy image analysis tools to break down, to segment out the normal structures of the brain. There are various approaches to doing this. Just showing you some examples here, the T1 weighted image, the T2 FLAIR image. Here the computer has told us where the cortex is, where the white matter is, where the thalamus, the deep gray matter nuclei, such as the caudate are, and then in red where the lesions are, the focal lesions. And that works out pretty well when you compare it to what we can see or pick up by our own eyes, and then here rendered in 3D where the computer thought the lesions are. And so in clinical trials, it's very helpful to be able to do something like this, particularly in trials that are done across multiple sites, where you can quantify the number of lesions, where they are, and then detect whether anything new is occurring on the drugs, on the drug that's being tested. And it turns out that there is a tremendously tight correlation between the effect of a drug on the incidence of new lesions and on the presence of clinical relapses. And so that's shown here in a meta-analysis by Sormani, who looked at, on the x-axis, the effect of a drug on the MRI, and on the y-axis here, the effect on reducing the number of flares or relapses that occur. And you can see the correlation is extremely tight across multiple studies, so that you really, on some level, for drugs like this, we have a marker on MRI that is so good that it can actually tell us what the patient will experience on the clinical side, which is what's important to the FDA for getting a drug registered. But it's actually even better and more valuable than that, because if you look, this is the correlation of the MRI and the clinical outcome in the same trials. But if you then take early phase trials. So normally when a drug is tested, it'll go through a small phase 2 study, proof of concept study, where you're trying to get enough data to say, is this worth testing in a very expensive multi-million-dollar phase 3 study in hundreds, if not thousands of patients. And using this MRI outcome, we can do these proof of concept phase 2 studies very rapidly, on the order of 4 to 6 months or so in roughly 10 or 12 patients. And if you look at the effect on the MRI in those phase 2 early proof of concept studies, again here on the x-axis, and look at how that correlates with the phase 3 clinical outcome, the relapse outcome, again, the correlation is very, very strong. So if you're a drug company and you have a compound that you want to see whether it's going to be effective in MS, for reducing new lesions and new inflammation, if you do these early, small, quick trials, you know you have a pretty good bet for going ahead. So then you worry about the safety profile primarily, but for an efficacy point of view, you can predict that extremely well. And the way to do that was actually worked out here at the NIH in the 90s based on those monthly MRI scans that I told you about. And why does that work? It works because these gadolinium-enhancing lesions correlate with the presence of new inflammation in the brain. That was shown in this paper, again from the NIH, where somebody in the very early days, this was 1991 or 1992, presented with a very aggressive case of MS, had multiple gadolinium-enhancing lesions in the brain. This is an old MRI scan. And succumbed to the disease, and you can see very intense inflammation in the areas where the gadolinium was leaking into the brain. And then again, by these monthly serial studies, it was determined that the incidence of a new lesion is roughly 10 times as great as the incidence of a flare, of a clinical relapse. So the MRI outcome is that much more sensitive than the clinical outcome, and that's why the trials can be shrunk down into these short 4 to 6 month blocks in small numbers of patients. And just to give you a visual idea of why that's the case. So this is data from Harvard, where they did actually weekly MRI scans of patients with active MS. This is back in the early 90s before any drugs were approved. You can see the plaques on the T2 weighted images, and then as I play this image, it's really dramatic. You wouldn't see this these days. Sorry, let's see if I can get it going. You can see that these plaques, these lesions, they appear, they grow rapidly over the course of several weeks, then they shrink down as they begin to repair, and they are popping up all over the place. So let me just play it one more time because it's sort of dramatic. Okay, and so you can see these things accumulating, and this person happens to be relatively active in terms of forming new lesions. But the drugs that we have, and particularly the latest generation, are really effective in suppressing that from occurring. But the question comes up, if you take somebody with early active MS and you really suppress the new lesions from occurring, what's going to happen to them down the road? That's a huge question in this disease. And so that sort of segues into the very last thing we wanted to talk about.
Alan, you told us a little bit about how in more recent years, despite not having these relapses, what you have been noticing is accumulation of symptoms over time. And this is really very typical of the later clinical course in MS. Alan's symptoms have been relatively modest, but what typically ensues after about 10, 15 years of relapses, especially in untreated MS, is that in 70% of untreated MS, the relapses will decrease in frequency and we'll begin to see this very slow accumulation of disability over time. And this is usually associated also with the disappearance of these new contrast-enhancing lesions, and often even not really very many new lesions being noticed by MRI either. While, and here I'll just click through those, while what we will see is a decrease in brain volume, and over time we will have seen an increase in lesion load. And this is thought to imply that in the earlier years of MS, there's really a predominance of inflammatory mechanisms, and that later in the course, we have a predominance of neurodegenerative mechanisms underlying the subsequent course. About 10% of patients actually present with a neurodegenerative clinical course from the get-go, with very slow progressive accumulation of disability and virtually no relapses, and these are called primary progressive patients, while secondary progressive denotes the more typical course. It's more recently been suggested that this may not be that there's no more inflammation. We know that there is inflammation by pathology, but maybe there's been a change in the type of inflammation. In particular, compartmentalization of inflammation has been identified and is not unique to MS. In other chronic inflammatory illnesses such as rheumatoid arthritis or Sjogren's syndrome, we do see the development of tertiary lymphoid structures in the organ where there is chronic inflammation. And similar types of structures have been identified in MS as well, in the leptomeninges, and have been suggested to possibly be playing a role in this progressive phase of the illness. As the triangles on the bottom suggest, though, with the reduction in the contribution of inflammatory mechanisms, this stage of the disease is also less receptive to treatment by the approved medications, which in fact have almost no impact on the progressive accumulation of disability late in course. What we do see is that beginning treatment early seems to delay and in many people much improve the ultimate outcome. But once that phase has begun, there is almost no impact by the agents that are available today.
So just to show what that looks like on MRI, we talked about the neurodegeneration and the loss of brain volume that can occur in progressive stages of the disease. So this is a patient who we've seen at NIH, tracked over 19 years and just put together dozens of MRI scans just to show you what happens over that long period of time. So, oops. So this is not weekly scans. These are mostly annual scans or more frequent than that. And you can see the age on the bottom, 53, 54. And as you go through this, you can see the expansion of the ventricles of the cerebrospinal fluid at the expense of the brain tissue. But there are really no new lesions that are popping up, or very, very few new lesions that are popping up over this period of time. So really different from that early active case that I showed you. And by age 69, in this person, there's been tremendous loss of brain tissue that occurs. So let me run that one more time again, just because it's very, very typical of what occurs in this disease. And the rate at which that occurs is, on average, about 0.5% of brain volume per year. And so 0.5%, 0.5%, 0.5%, it really accumulates. It sort of compounds over time. The typical rate of brain volume loss is probably about 0.2% or so in the general population. So it really, it's substantially different, and it gets greater over the years. So by 69, this is very, very large cerebrospinal fluid spaces. A lot of brain atrophy has occurred. So again, about 0.5% per year. And it turns out that if you do that same analysis that I showed you before, asking whether the effect on MRI of the disappearance of lesions is predictive of the clinical outcome, that's shown in the middle here. The atrophy effect is less strong, but still present and synergistic with the lesion outcome. So understanding the effect on disability in this case, which is not relapses, disability, really helps to know what is the neurodegenerative component of the disease. In the lab, as I mentioned, we can segment the brain into its component structures. Again, on T1 weighted image, I haven't shown you yet a coronal image of the brain, but that's one of them. So here's the hippocampus, for example, brainstem over here. We can separate out the different parts of the brain on high-resolution sequences like this and measure their volumes over time. So here is an example in multiple sclerosis. This was a paper we published a couple of years ago, actually looking at 2 large cohorts seen at the NIH, one of those cohorts was actually the cohort of patients who had been studied, who had been in the clinical trials of daclizumab, showing the rates of brain volume change over time. In the gray matter here, so you can see this, a lot of noise in these measurements, but a steady decline that occurs in most people, regardless of the age at which it occurs. It actually doesn't seem to accelerate with age, at least in this age range of 20 to 60 that I'm showing you here. It may start to get steeper after that. But interestingly, in the white matter, it's quite stable over time. And that's interesting because you think about MS as a white matter disease where the lesions are demyelinating lesions that occur in the white matter. But it turns out that in the white matter, the tissue is generally not lost, but rather replaced by scar tissue for the most part. Whereas the effect of tissue loss is actually in the gray matter where the neurons are, where the cell bodies are. And because the brain is made up largely of, in simplistic terms of gray matter, white matter, and cerebrospinal fluid, we can actually see this effect compounded if we measure the volume of the cerebrospinal fluid, as you can see here. And so this is turning out to be probably our most effective way of testing whether medicines that might influence the degenerative aspect of the disease, that might protect the neurons or repair them, may be effective. And my final slide was just, Irena mentioned this recent realization that inflammation occurs not just in the brain, but also in the meninges and the membranes that surround the brain, where actually lots of the immune responses in the brain occur, and that inflammation may be persistent over time. It's detectable at autopsy, and it may be associated with some of the degenerative components of the disease. And recently, we have been able to actually observe that in vivo using a particular kind of contrast post-gadolinium MRI that I didn't really have time to talk about. But just to show you some examples in a case that later came to autopsy here, where you can see this focal area of gadolinium leakage inside the meninges. It's not in the brain, it's around the brain. But when the tissue is analyzed, you can see that there is a loss of myelin protein in the cortex as well as the subjacent white matter, and an inflammatory perivascular infiltrate within the meninges itself. And we found that this finding was almost twice as frequent in people who had progressive multiple sclerosis as in those who had relapsing MS, and it accumulates over time. So we have some hope that we'll be able to develop brain markers, non-invasive or minimally invasive markers that tell us about the chronic inflammatory aspects of the disease. And the goal ultimately, from our point of view, is to sort of address some of these big unsolved questions in MS, one of which is how the disease starts. So it might be EBV, it might be many, many things. It might be different in different people. How is tissue damaged within these focal lesions? How is it repaired? That came up before. We didn't really talk about that very much. A huge question from the patient point of view is whether chronically damaged tissue, scarred tissue, can be repaired, can be remyelinated. That is an open question. That's a very hard thing to achieve. And then, of course, what causes clinical progression? Why do some people progress and not others? And can we stop that? And I think that should be possible. So I think is that it? That's it. We're done.
Okay, well, thank you very, very much. We do have a few minutes. If you have some questions, I would ask that you please use this microphone because there are people who are listening and they'd like to hear the questions as well as the answers.
Thanks, that was a great presentation. I'm curious, what happens to the oligoclonal bands with the latest treatments? So for example, the antibody treatments, do the bands persist? And then following on that, is damage mediated by any of the antibodies or B cells, or is it known that damage is mediated by the T cells?
Want to take it?
Oh, I can start. So historically, no treatments have affected oligoclonal bands. And the pattern of oligoclonal bands in patients with MS remains extremely stable over time. More recently, with some of the more robust immunosuppressive agents, there have been reports of bands disappearing. I'm not sure yet whether that will be confirmed and whether that will remain a finding, or how exactly that will affect prognosis or disease course.
But particularly stem cell transplant is the one where people have been saying maybe it will occur.
That may be, but it hasn't been,
No,
we haven't seen
those
it
case
yet.
reports,
Yeah.
right?
Yeah, and not in the studies that have been reported. What is the role of antibodies in the disease itself, I think, is still a question. Certainly, the disease seems to be largely driven by T cells, and that's sort of the dogma. We know from pathology that there is a role of complement and antibodies as well, but how much is driven by that is unclear. More recently, anti-B cell therapies specifically have been shown to be extremely effective, but exactly by what mechanism that's working is unclear, and it's mostly thought that it's probably indirectly affecting T cell function, and that's actually the way that they are so effective. And that's also because, again, oligoclonal bands don't disappear with that type of treatment, and most of those strategies, which are anti-CD20 treatments, don't actually affect plasma cells. So,
Do insurance companies cover the cost
of treatments?
that's approved by the FDA?
So when it's approved by FDA, then yes, I think that that's generally the case. I think that some patients may have restrictions on what treatments they're allowed to initiate treatment with. And if somehow a neurologist wrote that you have primary progressive MS, then that can become problematic. But for the most part, I think patients have access. And there are also assistance programs by pharma companies for uninsured patients or patients who can't afford treatment. And so we haven't usually found it to be a problem with getting patients on treatment, even though possibly there might need to be a bit of back and forth to get them on the treatment that you want to initiate. We've also further had experience with off-label treatments. Patients coming off the daclizumab study, the very first studies that we had here at NIH had done very well on those drugs, on the daclizumab, had not responded to previously available medications, and we were able to convince almost for all of those patients that the insurance company would continue to cover the cost of staying on daclizumab, which at the time was still available under a different drug name. But I don't know that it's always that easy.
Can I ask one more question? So in this era of big science, so has it been done, is it even feasible, the same way as you're following a patient's course with MRI, is it possible to look, for example, at the changes in their, I don't know, their microbiome, their metabolomics, even their gene expression, certainly their inflammatory mediator expression, sort of before, during, after? I mean, it may give some clue as to what's turning it on and what's turning it off. Is that in the ballpark?
Oh, it's beginning to be done. I actually just recently was invited to a conference at Google Life Sciences, which is interested in now that Tom Insel, who was head of NIMH, is at Google now. And so he invited me to talk to a group there where they're actually planning on applying big data on the Google scale methods to MS, and they're interested in, where are the opportunities for that sort of approach. Yeah. So certainly the ones you mentioned, and even in the MRI approach, I mean, I think methods for image analysis that can apply to large heterogeneously collected data sets are slowly being developed. and the computational infrastructure to deal with sort of these massive data sets is only now beginning to be marshaled. So I think it'll be interesting to see. I mean, from the point of view of somebody who runs a lab, I'm sort of always kind of caught between this idea, like, feed lots and lots of data into a computer, and then the answer will emerge, and then, doing a hypothesis-driven experiment, which I'm still partial to, but maybe I'm wrong.
But you're of the younger generation.
I
You
know,
should be
but I think I'm a
jumping.
throwback. My daughter tells me, in my musical tastes, I'm a throwback. So I don't know what.
All right,
else to
listen,
go.
I want to thank you on behalf of all of us. That was really, and thank you particularly. And so thank you, Alan. And we certainly wish you all good fortune and glad you're in good hands.
I am, totally. Thank you.